Good afternoon, and welcome to the webinar Preventing Opioid Overdose at Reentry through Jail and Community-Based Programs. I'm Dan Abreu, and I'll be your moderator for this webinar. By the number of registrants for this webinar, it's clear that the topic of opioid use is of critical interest across the country. As you can see, the participant numbers are still climbing, and we're approaching 1,000. The issue is especially urgent at release when there are risks of increased mortality and poor connection to treatment when people are released from jails and prisons. Hoping not to steal the thunder of our presenters, I like that both presenters will be discussing the importance of housing, which provides the foundation for sustained recovery. And I think we're going to have a very exciting, very exciting presentations and a question-answer session. But first, we have a disclaimer. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Some housekeeping. If you have questions, please submit your questions to the presenters in the Q&A pod in the lower portion of your screen. The presenters will address as many questions as time permits at the end of the presentation. There will be no phone questions taken. There will also be polling. So when prompted on your screens, please respond to the open polls in the polling tab, and the results will be shared once the polls close. And we have a poll coming up right now. Yes. Oh, okay. So you can I can see, okay, we're getting responses now. Great. This webinar is being recorded. Slides will be disseminated in the days following the webinar. A certificate of attendance will be available for download at the end of the webinar. This certificate is for personal portfolio use only and is not eligible for pre-approved CEU credits. So our agenda today, following the completion of my comments, John Berg, Senior Public Health Advisor, will make some introductory comments, and then our presenters will be Michele Worobiec and Dr. Bruce Herdman. And at the close, we'll be having a question and answer session. So now I'm going to turn the presentation over to John for opening comments. John?
Thank you, Dan. I'd also like to welcome everyone to today's webinar, Preventing Opioid Overdose at Reentry through Jail and Community-Based Programs. We appreciate you taking the time today to participate in today's informative webinar. Opioid overdose continues to be a major public health problem in the United States. It has contributed significantly to overdose deaths among those who use or misuse illicit and prescription opioids, including heroin, illicit fentanyl, and prescription opioids. Drug overdose is a leading cause of death among formerly incarcerated individuals. Prisoners and jail inmates released to the community are between 10 and 40 times more likely to die of an opioid overdose than the general population, especially within the first few weeks after reentering society. Jails and community-based programs are well positioned to work together to help address this crisis and prevent overdose deaths among those being released back into the community. An important area of concern for SAMHSA is promoting policies and practices to lower the risk of overdose, specifically for persons with opioid use disorder who are or have been in contact with the criminal justice system. This webinar will introduce a framework of critical activities targeting those being released from the criminal justice system who are at the highest risk of opioid overdose to ensure continuity of treatment services and the necessary supports to lower the risk of overdose during transition. Recently, SAMHSA released an evidence-based resource guide titled Use of Medication-Assisted Treatment for Opioid Use Disorder in Criminal Justice Settings. This guide focuses on using medication-assisted treatment for opioid use disorder in jails and prisons and during the reentry process when justice-involved persons return to the community. It provides an overview of policies and evidence-based practices that reduce the risk of overdose and relapse. Another SAMHSA resource available is the Opioid Overdose Prevention Toolkit. This toolkit offers strategies to healthcare providers, communities, and local governments for developing practices and policies to help prevent opioid-related overdoses and deaths. Both documents will be provided for download at the end of the webinar as a resource and also can be found on the SAMHSA website at samhsa.gov. We are pleased to have Michele Worobiec and Dr. Bruce Herdman present about this very important topic and want to thank them for sharing their expertise today. I would also like to thank the Gain Center and their staff for their work in developing and facilitating today's webinar. And at this time, I will turn it back to Dan.
Thank you, John. And now let me introduce our first presenter, Michele Worobiec. Michele is Vice President and Chief Counsel for Treatment Alternatives for Safe Communities. She provides executive leadership in corporate governance, legal risk management, policy and legislative initiatives, justice system relations, and national and international consulting. She has served previously on the bench in Ohio for 7 years, presiding over criminal and civil cases, as well as the drug, mental health, and veterans courts. She was previous policy counselor for the Supreme Court of Ohio, and she holds a number of leadership positions, including serving as a board member of the National Alliance for Model State Drug Laws. Dr. Bruce Herdman is Chief of Medical Operations at the Philadelphia Department of Prisons in Pennsylvania. He has held numerous healthcare administrative positions in Philadelphia, including Executive Director of the Philadelphia Mayor's Commission on Health, Senior Vice President for Psychiatric Services at Pennsylvania Hospital, Vice President for Risk Arrangements and Ancillary Services at Independence Blue Cross, and Senior Vice President of Provider Network Management at Keystone Mercy Health Plan. He is responsible for the delivery and quality of the medical, behavioral health, and dental services provided to over 25,000 incarcerated individuals annually at the prison in the community. So before we introduce Michele Worobiec, we're going to look at a cross-section of who's participating in our
Sorry.
All right, so in terms of demographics, it looks like most of our group is about half is urban. Go up a little bit. So law enforcement, 65, judiciary, 27. Another large group with corrections and parole and probation. And the public health, community-based. So there's a fairly broad range of participants on this webinar across the health and criminal justice domain. So, Michele, I'm going to turn over the webinar to you at this point to begin your presentation.
Well, John and Dan, and as well as the rest of the team over at the Gain Center, thank you so much for including me as part of this important discussion. I can kind of relate to a lot of these demographics. I've been involved in the courts As you heard from the introduction, I'm now in Chicago, but certainly came from Ohio, which has a nice mix of medium-large cities as well as rural areas. And I can honestly say that the content that we're talking about today has application across the board. Also, although I can't see anybody doing this webinar, it's been really fun to see some of the names pop up, some familiar names and faces, so I'm glad to see you joining the webinar. So with that being said, I'm going to start off with a basic framework that was developed a couple of years ago to really target preventing opioid overdose death at reentry. And then you'll have an opportunity to hear from Dr. Herdman and then myself again about some real-life models that put this into practice. So at the onset, when we look at critical activities, there are many, but 5 have been identified that are crucial and impact that immediate transition from an institutional setting to the community. These probably won't come as a big surprise, although you'll have a chance to see and learn about some of their nuances and application. So minimizing drug-enabling housing. During that first 2 weeks post-release, making sure that there's critical attention so no one slips through the cracks, including rapid access to appropriate substance use disorder treatment. Of course, minimizing drug market activity in the community is critical, as well as maintaining the support for participants beyond that 2-week period so they are able to engage in ongoing and successful long-term recovery. So what impact do we expect from this? This slide shows the gears clicking together. And so when we are able to implement these 5 critical activities, not only do we see an impact on a reduction in crime and drug use, but we see community safety increased. We save lives, which is obviously one of the points of the webinar here today to discuss that, as well as to help individuals achieve successful recovery. One of your reactions may be that these 5 critical components would be helpful for anyone, but the framework is really designed so that we can target those individuals that are absolutely at the highest risk. How do I identify them? Certainly if someone has shown a history of substance use, including past overdoses, as well as if they have had an overdose reversed with naloxone or Narcan, they would absolutely need to be a focus of these kinds of activities. If someone is in your institutional setting in a jail or a prison, oftentimes there is some kind of a medical intake that's performed at those facilities that would be able to shed light on information to let you identify people that are at the highest risk. Clients may also share with you information during self-report that alerts you to their need or a urinalysis, typically something done during the intake process. Certainly you can gain some useful information at times from their arrest and conviction records, particularly if those activities shed light on some potential significant substance use. And more, there is some limited yet structured activities to the prescription drug monitoring program that gives you information regarding opioid prescribing. Getting into then the 5 components and unpacking them a bit, as we heard in the introduction, and it's no surprise, housing is one of the very first things that we need to be concerned with. And when we look at housing, I'm really talking about that more broadly than literally the house that someone is going to stay in. It's that whole primary physical environment that is going to be the first place that welcomes them back into the community. So it is the house, but it's also your neighborhood. Oh, thought I heard some comments. It's your house, it's your neighborhood, the family and visitors that are entering into that environment. It's also likely that when you're transitioning back into the community, individuals have quite a bit of unstructured time. So when we look at people, places, and things, all of those circumstances are going to be wrapped up in this home environment, including a good deal of triggers. So if someone is returning to an environment that's familiar to them, then those are some extra factors that would need to be taken into consideration. How are you going to support this individual transition back into an environment that may be the best available to support and to minimize drug-enabling housing, and yet they're likely to have some impact that you would want to wrap around right away. What's the easiest way to look at the housing situation? Take a look. Make sure that you are familiar with not only the house and the people in the household and activities there, but also that whole neighborhood. How that house is situated in relationship to any reporting activities, to treatment, and to other life activities. And then take a look at the housing not only initially when someone is reentering into the community, but periodically. They may not stay in that initial housing placement, or the conditions of that placement may change over time. The second critical activity, as we had mentioned, is minimizing the overdose death within 2 weeks of release. And we know from decades of research that the reason why this is a critical period is that there's a 12 times increase in overdose deaths upon release from any residential setting. So here we are talking about the corrections, jail, as well as prison settings, but this is just as true as someone is being released from residential treatment and they're transitioning back into the community, or if they're in some other restricted setting where substances are not available. Why is this a key issue? It has to do with the tolerance for the higher doses that no longer exist when there has been a period of sustained abstinence. And specifically with opioids, it's looking at respiratory suppression. So individuals who have been in our correction system for a longer period of time, if they leave the system and use at the same rate that they were used to using before they came in, the respiratory system will not be equipped to handle that same level of substance. There's also, and it's not new, but it continues to plague us, the introduction to fentanyl. So again, depending on whether or not someone has been exposed to that environment, fentanyl is now being referred to as the third wave of this epidemic behind both prescription opioids and heroin. And we are realizing more and more that it's not just found in opioids, that it also is present with cocaine and other substances. So we need to be alert on as to the impact not only for someone with history of opioid use, but also other substance uses. I would also say, and as a reminder from the earlier slide, that the risk for overdose death in this area is higher than all of the other heightened risks at reentry. So we've heard about housing, we've heard about the critical nature of the first 2 weeks due to respiratory suppression. So it makes sense that the critical activity number 3 is maximizing our rapid access into treatment. And by treatment, what do we mean by that? We certainly want clinically appropriate treatment. And I know I have seen justice decision makers who sometimes prefer residential treatment or may have preferences regarding other modalities of treatment, just encouraging you to make sure that you have a clinically sound assessment that takes into account substance use disorder, other co-occurring illnesses such as mental health illnesses, and the full range of clinically appropriate treatment that would need to be available, both behavioral health as well as potential for medication-assisted treatment. Sometimes treatment may begin in the institutional setting. It needs to be continued in the community, and certainly if someone requires residential treatment upon successful completion of that level of care, they need to be transitioned down into other levels of care that transition them and support them back in their own home environment. Something I definitely want to point out on this slide is that we don't want to wait until someone expresses that they are motivated or ready for change. The research shows that engagement in the required treatment helps the individuals to shift the motivation to more of an internal motive to attend treatment. And so don't discount or don't feel that it is appropriate to require the readiness for treatment before they're engaged. What you need to do at this point during this high risk period is to make sure that people are engaged and showing up at the appropriate level of care and allow that clinical treatment to have its impact, including on motivation. The next critical activity is minimizing the drug market activity. It's the one that you are not going to be doing directly with your clients, but it certainly impacts the availability of the substances that are used by your participants. So here on the slide, you see some information from the National Network for Safe Communities, and they do have a drug market intervention kit. It is absolutely worthwhile to take a look at these materials. From the demographics that were shared at the beginning of the webinar, it's clear that many of you are leaders in your community. You're well informed of the needs in the community, and you may be in a position to convene the key decision makers and stakeholders in your community and make an impact. And then finally, minimizing overdose deaths beyond the 2-week period. So we talked about the importance of the 2-week engagement. The research tells us that there continues to be a heightened risk of overdose death beyond that. It could be 4 weeks and then even into 6 and 8 weeks. Of course, even after the research shows us that someone has transitioned successfully back into the community, transitions within their life can be triggers. Special events can be a trigger, sometimes even decreasing to a lower level of care or to increased responsibilities would indicate a need for some particular attention to social services as well as treatment services. I know at TASC we do case management services, and we continue to check in with our clients every time we meet with them. We do some proactive questioning to see if circumstances have changed that would necessitate some higher intensity case management or higher intensity interventions, and then we continue to monitor them to see when it's safe to back off on them, but we always keep on the radar in a very proactive manner that as life changes, treatment needs and other supports can change as well. So at this point, initially after the 2 weeks, we were very concerned about respiratory suppression and making sure someone had their solid start in the community. Here the focus continues with that, but we're also turning toward ongoing engagement and retention, recognizing that substance use disorders are chronic and recovery is a lifelong process. So as I promised, we are presenting the framework first, and then we're going to go in depth into some more tangible examples of how this looks in real life. And so to summarize the framework again, we want to make sure that that home environment is going to be supportive of a life that does not include drug use. That tight wraparound, making sure no one slips through the cracks during the first couple of weeks, and that they are retained in these efforts throughout recovery. Making sure that there is rapid access to all the clinically indicated and necessary treatment, and it's adjusted as needed, both increased and decreased as it's safe to do so, and certainly exercising leadership in the community to articulate the needs for resources and also to minimize drug market activity that negatively impacts our clients as well as the community as a whole. So that wraps up the framework. I don't know if I hand this off to Dr. Herdman, so if I do, I can at least verbally transition to our next presenter, Dr. Herdman, and then I'll be back on in a little bit to give you an example of some of the things that we do at TASC to fulfill the framework.
Okay, thank you, Michelle. We will hold questions until the end of Dr. Herdman's presentation. So at this point, we're going to turn the presentation over to you, Dr. Herdman.
Thank you very much, and
Slides will be coming up in 1 second.
Well, thank you, and welcome everybody. Let me introduce you first to the Philadelphia Department of Prisons, and then spend a fair amount of time discussing specifically the evolution of medication-assisted treatment here. This year, we will probably see 5,000 individuals who are opioid use disorder patients, providing methadone maintenance to 500, starting about 3,300 on Suboxone and offering Vivitrol as well as cognitive behavioral therapy. So it's a substantial program. I'm sure that if I can get to the next slide, that this distribution of charges is probably similar to what people see in their own jurisdictions. The primary charges here in Philadelphia are drug-related, even though it's been several years since the district attorney decided not to charge individuals who were found to have recreational amounts of marijuana in their possession. Most of the people that are here, a good many of the people here would be in state mental institutions if we had them, but there are a fair percentage of people with significant charges over 20% with murder, rape, Megan's Law violations, and arson. The characteristics of the population are that 85% of the folks here are of color. That compares unfavorably to the citywide average of about 50%. But the correlation is probably greatest, not with race, but with poverty. The city of Philadelphia has 1.7 million residents, great wealth, and great poverty. About 700,000 residents of Philadelphia, for example, are receiving medical assistance. 80% of the people that we see here in a year, and that's about 25,000 individuals, are from what the federal government designates as medically underserved areas. They're like a food desert, they're a medical desert. So they are economically deprived. Although they self-report finishing 11 years of school, the reading level of those folks that have not completed high school, and that's almost everybody, is about 5th grade. That's not because of intellectual disability. It's because people are either not going to school or going to school and not being educated. 80% of the people here have been here before, and the average number of incarcerations is 6.5 unless they're seriously mentally ill, in which it pops up to 7.9. This is the county jail, even though it's called a prison. And actually today, about 48% of the people here leave within 14 days. So it's a very rapid turnover, which makes us work very hard to provide diagnosis and treatment as early as possible while people are here so that we can get them started with the hopes of having continuity of care after release. Commonly in public health, we talk about the illness burden. We here try to think of it as an illness opportunity, because with people here for some time, we have the ability to intercede with this large group of people who are not receiving regular care in the community. And because of their substance abuse and because of their economic poverty and lack of employment, have rates of disease that are significantly higher than average. So the city's average for HIV, for example, is a little less than 1%, and we're at 2.5%. We'll treat about 700 people this year for HIV. Almost 40% of the folks here are on the behavioral health caseload and medicated, and 16% of the total population is seriously mentally ill, meaning schizophrenic or bipolar disease and the like. Seizure disorders is very high. That's related to substance abuse. Although we don't test everybody for substance abuse when they come through the front door, we did a study 2014 using this data from 2013, and it shows the percentages of individuals that have come in on various medications. Unfortunately, we didn't collect polypharmacy information. We're about to redo this study, and we'll use polypharmacy information. And another change, by the way, is that in 2013, 14% of the folks coming through the front door were abusing opioids. It appears now to be closer to 20%. And as Michele said, fentanyl is infiltrating not just heroin, but many other medications. And the city of Philadelphia has one of the highest fentanyl heroin overdose rates of any metropolitan area in the United States. We expect this year, and the tally's not complete because the medical examiner's work is not complete, but for 2019, we believe it will be over 1,100. Services here are provided by two for-profit vendors. Horizon is one of the nation's largest providers of physical health care services in corrections. They have 250 full-time staff and just about 250 part-time staff. Centurion, which used to be called MHM, or Mental Health Management, provides behavioral health services. They have 123, actually, individuals. And we contract also with AmeriHealth, a subsidiary of Independence Blue Cross, that they do all of our contracting for rates with hospitals and specialists and pay all of our claims. Horizon has been here more than 20 years, and Centurion more than 12, even though we put these contracts out to bid every 4 years. We have a 3% vacancy rate in the medical staff. The history in Pennsylvania is that in 2014, the senior physician issued a standing order for naloxone, and then you can see in these next several years what the trend was: 702 deaths in 15, 1172 in 17. It went down a little bit in 18, but it's back up to over 1,100. So it was a major crisis, the result of which was that the Mayor Jim Kenney, formulated a task force in 2017 to address this issue. The subcommittee that was looking at corrections recommended expansion of the medication-assisted treatment program here at Philadelphia Department of Prisons. And that's what we'll talk about now in some depth. Since 1993, and maybe even earlier, the prisons offered the abstinence-based cognitive behavioral therapy, a program we called Options. As long ago as 2004, methadone maintenance was introduced. That service is provided by a community outpatient treatment program that comes on campus every day with pre-poured doses of methadone and goes into each of our 5 facilities 7 days a week. And as I mentioned, they will treat about 500 individuals. They also do some Suboxone maintenance now, although the number of people that are coming into the prison who are receiving Suboxone through illicit programs in the community at the time of incarceration is fairly small. The recommendation from the Mayor's Commission led us to do some things starting in 2017, one of which was to create a film that we show on the housing units every day. And we also show the same film to visitors. We have 2,000 visitors a week. The film talks about the risk of overdose, death, the symptoms of it, of overdose, the use of Narcan, how to use Narcan, how to obtain Narcan. And that was our first effort. And if anybody would like a copy of that, send me an email. I'll be happy to send you a copy of the video if that might be of use. And then we also started in 2017 issuing 2-dose nasal Narcan kits to the people that we feel are at highest risk of overdose. And that is anyone that in years past would have qualified for medical management of withdrawal using the COWS, the Clinical Opioid Withdrawal Scale, or CWA or BWS. And so we're giving out about 5,500 kits per year. I should mention that recently, because that's a fairly expensive proposition, and originally the distribution of kits was free from the state, but now the city has to fork over the cash for these kits. What we do is we get the kits in bulk from a pharmacy, commercial pharmacy, and we give the kits to inmates after they have legally been released from the jail, but before they leave campus. And that allows the pharmacy to bill medical assistance, and that transfers the expense from the city to medical assistance. We've done a lot of work over these recent years in enrolling people in medical assistance, and about 90% of the people that leave here today have either medical assistance coverage that was active when they came in, that is not suspended by the state, or suspended coverage which we have reactivated on the date of release, or for about 50%, we actually submit an application. So that allows people to have ready access to medications and facilitates their entry into programs, treatment programs in the community. In February of 2018, we introduced a pilot in the women's jail where we were offering buprenorphine, 8 milligrams, to women who are not being maintained on methadone or Suboxone, who were confirmed opioid use disorder patients confirmed by urinalysis. And about 90% of the women who were considered for this program participated in the program. That we offered cognitive behavioral therapy. We did not require it. And the reason we didn't require it was that the primary objective was to decrease the incidence of death in the first 2 weeks after release, and we didn't want to introduce barriers to people's participation. So far, participation for the buprenorphine patients has been voluntary. When a person is released, we were giving them a prescription for 5 days of Suboxone. The preliminary results from that pilot showed that more than 50% of the women filled their prescriptions. That was from PDMP data. And then we used claims paid data, Medicaid data, and found that 42% of the women received behavioral health or substance abuse or both forms of care in the weeks immediately following release, which was an initial engagement in rate of initial engagement in treatment that we thought was pretty promising. We're redoing that analysis now since we've expanded the program to cover facilities holding men, and we're going to be looking not only at initial engagement but at continuity of care after release and how that relates to things like whether or not somebody participated voluntarily in cognitive behavioral therapy. We expanded the program in the fall of 18 to cover facilities for men, and we ran into real concern on the basis of our prescribers. The prescribers have all been very eager to be trained to get waivers so that they could administer buprenorphine. But when we got to handling men, they were very concerned that because of the volume of prescriptions that they would be writing, because women are 10% of our population, and now we were going to add 90% to the program, that the DEA might get after them for prescribing what appeared to be more than what they were allowed to by their waivers. So we contacted the DEA and asked them if that was the case, and they said no, and we asked them if they would put that in writing, and they said no. And it took us some time and some political pressure to get the DEA to, on the phone, talk to all our physicians at one time to assure them that as long as people stayed within or close to the waiver, they wouldn't be bothered by the DEA. The other assurance that was very important was that when a person leaves the prison, they're no longer counted against the physician's waiver. So for the months from September of 18 until May of 19, we were not writing prescriptions for people when they were leaving. In May, what we did was we changed the program so that we were using Suboxone instead of buprenorphine to decrease the risk of overdose. And when people leave, we don't give them prescriptions. We actually give them 5 days of medication. I believe Rikers gives 7 days of medication to its sentenced population, but just like Rikers, only 10% of the people here are sentenced. Most people here are pre-sentenced, and we wanted to remove the barrier of people having to go to a pharmacy to fill their prescriptions as was necessary in the pilot. Some of the women that were reincarcerated from the pilot said that they would take the prescription to the pharmacy and be unable to fill it, not because of Medicaid, but because the pharmacy either didn't want to participate in the program or didn't want to give an addictive medication to someone that they knew from their own community was addicted. So so from May on, we've been handling men. We have about 300 people every day in the Suboxone program. About 60% of those voluntarily participate in cognitive behavioral therapy. We expect to treat 3,300 over a period of a year. And we will have, I think, preliminary data on the effectiveness of this program in about a month, which we'll be pleased to share at that time. So let me speak about the actual process. When a person arrives at the Philadelphia Department of Prisons, they arrive on a sheriff's bus or a police van. Our requirement is that we complete our medical evaluation of those people within 4 hours. Now they can be seen earlier than that if they have clear symptoms that require earlier intervention, but we finish everybody in 4 hours. That's an 80 to 120 question screening document that's administered by registered nurses, and all the answers are recorded in our electronic medical record, which automatically generates referrals for treatment. So if a person comes in and they say they're asthmatic and they're symptomatic, they'll be seen immediately. If they say they're asthmatic but they're asymptomatic, they'll be scheduled automatically for the next chronic care visit, which would normally be the next business day. And the 5,000 or so people that identify themselves as likely to withdraw from opioid use disorder are either referred to the outpatient treatment program that does methadone maintenance, or they are referred into for evaluation for our Suboxone program. On the second business day after arrival, that eligible person would be evaluated by a physician here who is board certified in substance abuse treatment, and the decision is made as to whether or not they should and can participate. 90% of the folks, as I mentioned, do participate, and they receive 4 milligrams of buprenorphine from stock, and then the prescriber at that point writes patient-specific prescriptions for 8 milligrams of Suboxone ongoing and for cognitive behavioral therapy, although that's voluntary. And then the individual is reevaluated periodically during the rest of their stay. On the next business day, they're met with by staff who sit with them and help them choose a community MAT provider that they hopefully will go to on release. and we send an electronic secure referral to that provider. And when the individual is released, we also send a discharge summary. It's a discharge summary that is like what you would receive if you were being released as an inpatient from the University of Pennsylvania Hospital. So it's a thorough release that's very useful for the folks in the community. And we do have the ability to electronically send portions or complete medical records almost instantaneously to any program in the community that wants additional information. Also, that same group assures that we have the information necessary to complete medical assistance applications in the process that I mentioned earlier. Let me skip this 2020 and talk about the issue. At the time when we expanded the program to cover the prisons that hold men, we ran into a problem in that the physician who had started the program for us, who was an internist that was board certified in substance abuse, decided to take a position as a medical director of a local hospital, and we lost his waiver of 250, and we were automatically over our waiver limit because we were still in the first year of all of the physicians here that had just gotten permission to see 30. So one of the problems is that although the waiver limit has been increased in the community from 30 to 100 first year, it still remains at 30 in the first year. We contacted SAMHSA, with whom we have good relations, and asked them if they would waive the waiver for us, given the problem we were in, and they said no. But they were very helpful in speeding the transition of another board-certified physician who had a limit of 100 to 250, which allowed us to, again, start enrolling men in the program. I mentioned the concern about the DEA. That concern has never been mentioned after that first tussle that we had. We had a 4% diversion rate. With buprenorphine, we crushed the pills and required the person to wait 10 minutes, and then they had to drink water prior to release to go back to their housing units. And the diversion rate was 4%, not quite 4%. When we shifted over to Suboxone, we don't crush the pills because that would decrease the effectiveness of the medication, and that does increase the diversion risk because it's easier to spit out a pill than to spit out a crushed material. And we are actually considering transitioning from Suboxone pills to film because the film dissolves much more quickly and is less likely to result in diversion. We did not have to increase the cost of the city for this program, even though it actually cost us about $1.3 million, given the very large volume of people that we're caring for. And the way we cover new programs is by finding ways to be more efficient. In this instance, we just signed an arrangement with Temple University Hospital that gave us access for HIV patients to 340B discounts, and that saved more than enough money to pay for this program. And I would encourage anybody in corrections to not rest on the statement, we've always done it this way, and to look for ways to find more efficient mechanisms, even though, in my experience, sometimes it's with chagrin when you say, why didn't I think about this 2 years ago? We administer the medications all at once. We take everybody to a gym, for example, in any particular facility, and the nurses administer the medication. Officers watch the individual while they're sitting. And that does contribute to stigma in that we're not exactly handling the dissemination of this medication the way we do lisinopril for hypertension, for example. And we are looking at ways, especially if we shift over to film, that we might be able to do the distribution through a regular pill pass, but that's not the case at the moment. In order to facilitate the sharing of information with community providers, we changed our intake consent form so that it covers all of the HIPAA and in Pennsylvania, some stringent behavioral health and HIV-related regulations about the sharing of information, so that we can easily give information to community providers when a person is released. And Michele already talked about housing, which is definitely an issue in Philadelphia. I'm trying to go back to say, here's what we intend to do this year. We offer methadone induction to pregnant women that come in. We actually send them to Thomas Jefferson University Hospital, which has a special program for pregnant women who are opioid dependent. But we don't offer induction of methadone to others, and I think we've just found a way where we'll be able to do that. We do offer Vivitrol, but the demand for Vivitrol has been de minimis, probably because of the availability of Suboxone. We are close to being able, I think, to do at least a pilot on offering Sublocade, which is a 30-day injectable form, which we hope to be able to use at least with those people who have been treatment non-compliant in the past after release. Our greatest success in assuring continuity of care is with our HIV program. 70% of those folks come in with controlled viral loads. We refer those people back to their current community providers, but the 30% that are not connected to a provider are visited by an advocacy group of peers, those peers in terms of their correctional experience and their HIV status, and that link results in an 80% first visit show rate. So we are working hard with a series of people to whom we refer MAT patients to have them come on campus and see patients here prior to release, hoping that the personal relationship that's established will result in increased continuity of care, something that we will be testing over time. We need to coordinate our releases also, particularly with the Department of Behavioral Health, since especially the 30% of the folks here who are homeless have a comorbidity in that department, and managing their housing via DBH, I think, will be a significant improvement. We're in the midst of a quite rigorous evaluation of the program that I mentioned. We have not yet started coordinating with probation and parole, although we do coordinate currently with the public defender, to some extent with the courts, and we have meetings set up now with the prosecutors to improve all those links that might make sure that people get the wraparound services that Michele mentioned earlier. So that completes my presentation, and I turn it back to you, Dan.
Thank you, Dr. Herdmans. And so now, continuing the webinar, we're going to go back to Michele Worobiec to speak about overdose death at Reentry, and she's going to focus on one of the programs at the Sheridan Correctional Center in Cook County. So, Michele?
Thank you, Dan. Before I start about this specific program, let me tell a little bit about TASC, just so you have the context of who we are and what we're doing operationally in Illinois. TASC has been around for over 40 years, so we got started when the Vietnam vets were coming back from the war. Interestingly, they were facing heroin addictions, and at the time there was some wisdom from the Department of Justice and actually President Nixon, who indicated that they did not want to take our veterans and use punitive approaches. They wanted a treatment-based approach. And so TASC was able to develop its specialized case management model that we still use today to be able to appropriately assess clinical and other needs for clients, to connect them to treatment, to monitor and partner with them as they achieve their goals and the justice partner goals, and have long-term recovery. We have statewide operations across Illinois, so obviously in very large urban areas like Cook County and Chicago, and in every other county across the state. So smaller urban areas as well as rural areas. Our client base is about half Medicaid, half uninsured, and we do have, for instance, with Sheridan, a contract with the Department of Corrections to be able to pay for services. And we provide the specialized case management for justice referrals across the entire justice spectrum. So we work with law enforcement, we coordinate with jails and help individuals transition out of their care. We have programs with state's attorneys and prosecutors, with judges, both pre and post conviction. We have probation violation programs as well as reentry programs. The essence of the work we do is the specialized case management, which certainly helps to inform our consulting and our policy work. And last year we served over 44,000 individuals and families. So have a lot of experience doing this. The one program I wanted to highlight for all of you today is one of our corrections transition programs. I'm highlighting Sheridan specifically because there was an evaluation done, so I can give some effectiveness data as well as some insight learned from individuals who are not successful. But again, we do this program in other locations as well. So specifically for this program, what it is designed to do is to allow residents, when they are getting ready for discharge back into the community, to engage in substance use treatment, vocational and educational programming, and transition planning while they're still located with the Department of Corrections. And as a condition of parole, if they are a member of this program, they agree to community substance use treatment and aftercare as clinically appropriate, as well as our case management for at least 90 days. So we're absolutely hitting that first 2-week crisis period as well as the weeks that follow until hopefully they've achieved that long-term stability more independently at the 3-month mark. So what do we do? There are several key players that partner in this project. You'll hear about the corrections role in terms of identifying participants in a moment. TASC does provide the specialized case management. What we do in this setting, there is a treatment provider who does the substance use treatment, so they provide the clinical assessment. Otherwise, TASC would do that as well. We also assess each individual for their strengths and their needs. We do service planning with them. There are client-driven goals that address their needs and also meet any justice expectations. We engage them in treatment. Again, here that's built into part of what they are doing in this residential corrections program. And we also make sure they're linked to appropriate social services that tie into the social determinants of health. We continue to work with them to make sure that they are, we use motivational interviewing, keep them engaged in all the supports that they need, and are there to identify any issues or barriers to their success so they can be addressed, including the need for higher intensity services. We have a grant to also offer medication-assisted treatment prior to release. That was specifically for Vivitrol. And then the parole agents are free then to address their program compliance and community safety issues, which would be their more traditional role. The Department of Corrections does identify who's eligible for the program. So it's voluntary. Individuals must be in the need of substance use treatment, and again, that's going to be based upon a clinical assessment from the contracted treatment provider. They need to have at least 9 to 36 months left in terms of time served to have time to participate in the program. They need to be eligible for placement in a medium security prison because that happens to be the facility where this program is housed. No disqualifying offenses, and also don't suffer from another, for instance, severe mental illness that would interfere with their ability to benefit from the treatment. So again, making sure that the individuals that are being targeted for this program are appropriate for the resources that are able to be offered. The admissions process, again, Department of Corrections will screen for the initial eligibility and make sure that they're supported by the clinical assessment. The case management work that we do that supports this transition, which is obviously the focus of what I'm going to talk about here, is divided into pre-release components as well as post-release. So pre-release, again, we do that strength and need-based assessment, so we have a sense of what the individual's needs are going to be. And we immediately work with them on discharge planning. So learning from them, where do they desire to live, what community are they returning to, where do they anticipate living, looking at what needs surround that. We reach out to treatment providers in the community and other needed service providers in the community to assure that placement will be available immediately upon release. And then similar to what we heard with Dr. Herdman, there's the issue of making sure that insurance payment is available. So we do quite a bit of the healthcare coverage navigation to ensure that Medicaid can be available upon release, and everything is well timed and coordinated. And like I said, for our participants, we have about half of them that are able to qualify for Medicaid. Our pre-release case manager then transitions the case to a post-release case manager who is located and serves the community where that individual resides after they return home. And so this shifts in, instead of the planning and initial placement, they are ensuring engagement into all of these services and that nothing is slipping through the cracks. They're going to stay in close contact, especially immediately upon release. We do our high-intensity case management so that we can keep close tabs on individuals and monitor their progress through communication not only with the clients but with all the providers. So we as well make sure that we have some intake packages that allow for that confidential communication and compliance with HIPAA and Part 2 and other applicable laws. And then we're in a unique position then to be able to identify any needs that emerge. So if housing no longer is stable for them, then we can address that right away. If they are transitioning through different treatment levels of care, we can make sure that they have appropriate care. If they've been transitioned down to a lower level of care and their needs have increased through triggers or transitions or other crises, then we can make sure that right away they have additional treatment services available to promote their stability. And at any point in time, once they've achieved that initial stability, if they need that high-intensity case management or high-intensity services, we're there to wrap around them. So what did we learn from the data about the program? We definitely found that the program promotes improved justice goals. And as you can see on the slide, the risk of rearrest for a new offense for participants was 21% lower than other individuals transitioning into the community. If someone was at Sheridan and participating in the program for at least 9 months, that improved rate now was 33%. And then you can see overall a 44% lower risk of reincarceration for any reason at all. What did we hear from our participants? They told us that they had an improved well-being. They were more successful in obtaining and keeping their job. They had improved levels of psychological and social functioning, and there was a reduction in criminal thinking patterns. And these are all things that we know tend towards stability and also promote a decrease in recidivism. They had an improved rate of aftercare admissions and completion. So through the coordination of our pre-release planning as well as our post-release team, we were able to have seamless connections and continuity of community-based treatment to build upon what they already completed at Sheridan. And we were also more successful in overcoming other barriers to effective reentry. The study that I am referencing here also took an opportunity to interview participants who did experience recidivism. And they wanted to find out, if you did experience recidivism, what were your challenges? And it will not be surprising to this group to learn that the things that we identified initially in that framework are really some of the discussion topics of the challenges that made it hard to continue to have stability. So I think it reinforces the importance of what we discussed up front. So it was particularly challenging for people that returned to their original neighborhoods. If someone was going to have returned to substance use, those individuals tended to return to substance use earlier. Also, if they were living in a neighborhood that was perceived as unsafe or where there was drug dealing, again, those were things that did not promote reduction of drug use and certainly were challenging factors for the participants. Activities, we talk a lot about people, places, and things, so certainly if they spent time with people who engaged in substance use or were engaged in criminal activity, then that was a challenge for them. If they were unemployed and unable to obtain employment, if they were to engage in criminal activity at all, that tended to be a risk factor for them, as well as gang involvement. And then if people did not complete their aftercare, that was a risk factor both for future criminal activity as well as return to substance use. And so why do I point that out? Because the recidivism rates are not reduced to zero. It helps to learn from our successes. It also helps to gain insight from individuals that still have some challenges. And I think it reinforces, again, bringing this back to that first slide that we saw together, it brings us back to the framework. So what are the factors that we know when we are effectively addressing them, they promote success, and when individuals have struggled, they cite that these were the factors that prove to be challenges. They need to have housing that does not support drug use, and ideally, as we saw in this program, that it is secured prior to release. the tight wraparound and handoff, not even a warm handoff, but really making sure that it's seamless. And this program facilitated between pre and post-release case managers, making sure that access to treatment that was started within the institution continues in the community and it is maintained at appropriate level of care and responds to changes in clinical needs. And I would also say that we need to have not only the clinical treatment, including medication-assisted treatment, but also those social services that are tending toward removing barriers from access to care and success and are focusing on social determinants of health. Minimizing drug activity, again, we saw in some of the data where communities were not safe places and where there was drug activity going on, that made it more challenging for people to be successful. And then, again, I think the program showed that ongoing specialized case management well beyond the first 2 weeks absolutely promoted stability. And I think that's it for my part of the presentation. And with over 1,000 people participating, my guess is we will have some questions and answers.
Thank you both for a very informative presentation. So now let's go to the question and answers so that you can further enlighten us. So, one of the questions, this would go to both, but maybe to you first, Dr. Herdman. What specific assessment instruments are used to assess strengths and just in your general OUD, SUD screening?
We don't have an instrument that assesses individual strengths or needs. The Social Services Department of the prison does do that in their own interviewing, and I can't speak to what instruments they actually use.
Is there anything you can offer on that question in addition?
Yes. Can you hear me? Am I muted?
No, you're good.
Okay, sorry about that. I thought I was muted. What we do is when we are doing the clinical assessment, we do a full behavioral health assessment that results in a diagnosis for substance use disorder. It's based upon the DSM-5. It is an assessment that we developed and has received approval for payment through our Department of Substance Use Prevention and Recovery, where we are licensed both as intervention specialists as well as treatment specialists, and all the Medicaid MCOs have approved it as well. So we do that. We have some screening tools that we use that are through Texas Christian University. They're available free of charge. They are great to help us flag if there are potential mental health diagnoses or other things that are in need of care, and that definitely informs our placement into treatment so we can select an appropriate provider that can handle those multi-diagnostic needs. And then we also use the ASAM criteria to determine the appropriate clinical level of care. So those are all things that we have built into our program system, but the DSM-5 diagnostic assessment, as well as ASAM level of care and any additional screeners from Texas Christian University.
Well, let me add then that in our intake process, we also identify individuals who have physical health diagnoses or behavioral health diagnoses, and since 80% of the people that we see on any particular day have been here before, we have, for some, a fairly extensive history that identifies what their comorbid challenges are. And when we are sitting with people to help them identify treatment programs in the community to which we'll make a referral, the data that's available talks about a long list of services that each of those community providers offers or does not offer. Do they offer extensive behavioral health treatment? Do they offer primary care? Do they offer case management? Are they specializing in housing? So to that extent, we do have a screening instrument. I don't think we have one that's named after the university that developed it, but it sounds like we're doing something similar to what Michele was speaking about.
Okay, thanks, Dr. Herdman. You know, there's a number of questions about housing, so let me just try to ask a general question, and then Michele will start with you, and then move back to you, Dr. Herdman. So there's questions about identifying housing resources, about whether this is permanent housing people are being moved into, or whether it's transition housing, whether it's recovery housing. So can you, and there's a housing crisis across the country. Housing has been a big issue, and there's actually a lot of pushback now in a lot of communities. Not in my backyard kinds of thinking that is making this whole issue more of a challenge. And yet it's such a priority. So I wonder if you could address broadly and then maybe specifically some of the ways you've, one, created more resources or removed barriers. Michele, can you start?
Absolutely. So one of the reminders I'll indicate for this particular program for us is that our clients are also under supervision by parole. So at times, there may be some specific requirements from parole about housing expectations. And so they would need to approve whatever the housing is, and we can be a resource to help find the best possible housing. So from a TASC perspective, we want to make sure that the client has a choice in what their housing is. We want to help inform that choice and connect them to the best possible housing that would fit their circumstances. And I would share across the full state of Illinois, it's not one single answer. So sometimes it is based upon the best that we can put together in terms of what the community has to offer for a resource. We are definitely in a position to be able to inform the state as well as specific locations about needs and advocate for more and appropriate housing. But across the program, there's no particular requirement unless the Department of Corrections would have a requirement for halfway housing or the like. We don't have a particular requirement for what that housing looks like other than making sure that it is the best possible housing that would promote the goals of our client. And we did engage in a pilot, and I think it's coming to a close. I don't have any of the data available. So we did have a pilot which had rent subsidy. So it was not specifically recovery housing, but it was rent subsidy for housing that would be appropriate and minimize any drug use.
In our case, the medical staff here are not specialists in housing placements, but we collaborate with a number of city programs that have that expertise. Not to say that there is adequate housing available by any means in the city, but for the Forensic Intensive Recovery Program is for substance use disorder patients that are under court order. That's about 1,000 releases from PDP, the prison, every year, and the housing arrangements are specified as part of that court release. Our links with the Department of Behavioral Health are particularly for seriously mentally ill patients, and I mentioned that's about 16% of our total population. And one of the things they focus on most is on safe housing for that population. For those people that leave our psychiatric hospital, we have our own 60-some bed inpatient licensed psychiatric hospital. Those that leave that are not capable of taking care of themselves, we will make arrangements, but those are usually not housing arrangements so much as longer-term hospital treatment programs. But for the great majority, now remember, this is jail. This is not a prison. So we don't really know. We don't have a discharge date for 90% of the people that leave here. So that does handicap us in our ability to make arrangements, especially in a housing area where something is available at 10 o'clock in the morning might not be available at 2 o'clock in the afternoon. So for the most of the people that leave here, they're leaving without a specific housing arrangement unless it's with family.
Okay, thank you.
If I could jump in, I would love to tell about a pilot project that we have had over the past couple of years that addresses that specific issue that you mentioned. It's a partnership with our jail, so again, getting out of this correction transition program from our prison reentry. This is a jail partnership with Cook County Jail, and we ran these, and we're still running a supportive release center. It is a place where individuals, as they're being discharged from jail, have an opportunity to stay for including overnight stay. They come, we are, like when people are being released from jail, as you mentioned, it could be at various times of night or day. They have the clothes that they were wearing at the time that they were arrested, which may not even be appropriate for the season. They're certainly not clean. Literally, the possessions are returned to them in the condition that they were collected at the beginning. And so we are able to offer individuals a place to spend the night, clean clothes. We do their laundry for them. They can shower. They can enjoy meals and snacks. They have hygiene packets that they can take with them. There's a nurse practitioner who is able to do a medical exam to see if there's anything that needs to be attended to, and we have case managers there that can make sure that they at least have some of those initial placements and a place to kind of regroup after you were discharged from jail, but before you're ready to take other things on. And so it's a fairly short-term program designed really to kind of fill that gap that was described. I think there are other places in the country that have something similar. So that's an idea that I can share. Again, we did it as a small pilot, and so far the data is encouraging that it was extremely helpful.
Thank you, Michele. There's no one answer to the housing issue, and a lot of it, in a lot of ways, it's community specific. But I always like the idea of a pilot, where you can show, number one, work out work through all the different barriers that you'll find, get a definable group of people, and then get some data that shows the impact and the effectiveness of the program, and then move on from there for sustainability and expansion. So, and I've seen that model work in a lot of different communities. You start with something that's doable, that you can find some funding for, and then get your data and evaluation in place, and then look to expand. A related issue to housing that always gets brought up as a big barrier, but very rarely gets firmly addressed, is the issue of transportation. And I wonder if either of you have run into those issues with your programs. Michele, why don't you start, and then I'll ask Dr. Herdman.
Absolutely. That is certainly a key barrier, especially depending on where individuals live. We piloted a telehealth project in a particularly rural area of the state to try to address and reduce the need for transportation, and we would love to engage in more discussions about expanding telehealth. So that's certainly one thing that can help eliminate or minimize some of the transportation burdens. When individuals are on Medicaid, transportation is included as one of the benefits, although we know from community to community the success of that and how effective the transportation is can have some variability. Quite frankly, we have case managers that will drive people to their appointments, and sometimes that's the only way that individuals are able to get from their home or to their appointment. We are also willing to meet with individuals out in the community, again, to minimize some of the transportation burdens that they would have. At times there are vouchers that are available. We have had programs where there was some community funding, and in one program, the weakest link was transportation. And so the grant was willing to fund basically some taxi vouchers and Uber and the like, rideshare vouchers, because that was the biggest barrier to people engaging and remaining in treatment. Sometimes it is helping individuals partner with their families and restoring some of those relationships so that rides and support are available. Again, not one size fits all, but clearly one of the big issues that we face. And without transportation, there is no ability to engage in treatment and the other activities that will promote recovery.
Yeah, I think that's a good approach. So a broad approach is certainly needed, but it certainly does need focus and attention by the partners. Dr. Herdman, anything to add?
Well, not to add in terms of assuring that people get treatment while they're incarcerated. It's not an issue for us, although it's an expensive proposition when you're sending 2,800 people a year off to specialty services, and they have to be in a van and with officers guarding them and so forth. But the more pressing problem is transportation really at release. And we do give transportation vouchers so people can use the public transportation system, which is awkward to get from the jail, which is in the northeast part of the city, to even to Center City, which is 10 miles away. We don't face the problems that statewide departments do, but some people have multiple conveyances to get on in order to get home. We do provide transport in winter months directly from the prison to shelters. There are a number of shelters throughout the city for homeless individuals. And then we have some pilots going on, as I mentioned, where peer navigators are coming on campus to meet with particularly needy patients prior to release. And one of the things that they try to do with the sentenced individuals, which is the only ones where we really know when they're going to be leaving, is to actually meet them here on the day of release and take them to their first appointments, which may be a medical appointment or arrangement for housing and so forth. But it is a big challenge.
So let me pick up with that reach-in approach that you're using for engagement, because there's a number of questions about engaging individuals in treatment. And can you talk about the effectiveness of having or how often it happens? I realize, in your jail, especially being so large in the short stay, how often the individuals in these programs that are getting referred actually get to meet the providers or have some contact with the providers prior to release, or or some kind of boundary spanner case management type of individual.
So you're right. I mean, the huge challenge is that 50% of the people leave in the first 2 weeks. If a person isn't bailed out in the first couple of weeks, their average length of stay goes from 70 days to 7.5 months. So the 50% that remain here past 2 weeks are available to be visited by these in-reach workers that you mentioned. And on the HIV side, for example, it could be once or twice a month just prior to release. We have data on the as I said, an 80% first visit show rate after release for that population. We don't have data yet on the in-reach pilots that we have going on with the seriously mentally ill, but the objective is to have these people met at least every 2 weeks.
Excellent. And I mean, there's a broad range of studies that show that in-reach engagement dramatically increases community follow-up. And Michele, you experience in your programs with in-reach or other types of engagement strategies at transition?
Sure. Yes, and as I mentioned, we have the pre-release versus a post-release case manager. So the pre-release case managers, honestly, I'm not sure about the frequency, so I will need to look into that and let you know. But I know the post-release case managers, they already have the connections made through the pre-release case managers, and they are in contact with clients within 24 hours of release to confirm that everything went as planned. Initially, those contacts during this high intensity or high frequency period is measured in days, and then we can gradually back down to weekly contacts or less often, depending on the stability of the client.
Okay, thank you. One issue I wanted to discuss, it was mentioned by both of you briefly, but I wanted to just spend a little bit, if you could expand a little bit more on often the specific needs of women can be overlooked when you're talking about the 90% of men that we're dealing with in the justice system. So I wonder if, Dr. Herdman, you could start, and then we'll ask Michele about differences in approach, strategy, or resources for women as opposed to men.
Well, you're correct. I mean, we devote significantly more resources to women overall than to men. It's easier in some ways with the female population in that the great majority of these individuals have children, and they seem to be sort of more motivated to take responsibility for what's going to happen to them after they leave, and so they're eager to participate in the pre-release training programs that we offer, both for employment purposes and life skills. And then we do have some agencies that come in regularly. So for all of our pregnant individuals, there's an organization called the Maternity Care Coalition that does prenatal care for us. They do doula visits for everybody that goes to a hospital to deliver, and they follow the individual as best they can for as much as a year after release. So with the seriously mentally ill patients, again, we're trying to use peer navigators to assure continuity of care after release, but we don't have data on the success of that program so far. By the way, we have full-time infectious disease and full-time OBGYN as well as full-time internal medicine here on campus. So a lot of those resources are devoted to women and as well as to juveniles that are incarcerated here.
Okay, thank you. And Michele, same question.
Absolutely, and I would agree that you need to find the appropriate treatment providers that are able to address those needs. So certainly housing needs look different when you have particularly women with children, and that is a common need. So trying to find appropriate housing that allows them to stay with children, or even residential treatment programs. If they are being released into a residential treatment program, something that would allow them to stay with their children. And so we've been building relationships and continue to build relationships with treatment providers that are able to address those needs. Medication-assisted treatment, again, you heard about the jail program utilizing Subutex, making sure that if women are pregnant, those needs are still being addressed. And we've had several women who also have particular medical care needs that need to be addressed as anything else. Trauma, so women in trauma, being sure to address for all of these clients. I think we assume at TASC that most of our clients have been exposed to trauma, and certainly the justice system can be traumatic for individuals as well. But being aware of particular trauma-related needs that women have, and again, focusing their referral to treatment providers that are particularly equipped to handle those. At TASC, we also have other programs that are geared toward families. We have a family recovery program as well as programs for moms and new babies. And so there are at times opportunities for them to utilize some additional services or programs from us that focus on, their needs, especially parenting, but women in general.
And just one quick follow-up question. Do you have any data on the women, the percentage of women that have custody-age children that are in your programs?
I do not have that data.
Yeah, okay. For us, it's, I believe it's about 80%.
Yeah, okay.
Yeah. I should add, too, just to follow up on what Michele was saying in terms of trauma. Certainly most of the residents here have experienced significant trauma. We have been participating in the SAMHSA-sponsored crisis intervention training to try to increase officer awareness of the effects of trauma and to intervene with, instead of with pepper spray, with conversation first to de-escalate situations with some success. So that's a very, that's only one toe in the water of trauma care, but that's our first step.
It's an important one. We have enough questions to continue well past 5 o'clock, but we have a few housekeeping items we still have to address before the close of this webinar. So I want to thank you both for what I think was a very stimulating webinar, as evidenced by the number of questions we had at the close. So I'm going to...
You're welcome.
Thank you so much for the chance to participate.
Okay, so... we're done. So, for additional resources on the topic, you can visit the SAMHSA website. There's recently published use of medication-assisted treatment for opioid use disorder in criminal justice settings. And there's also the SAMHSA Opioid Overdose Prevention Toolkit that are available on the website. In fact, so I'm just going to ask my colleagues here a couple of questions. So we're sharing it, and so they can download these right off the webinar then by going to the
It'll pop up and momentarily.
Okay. And so those are, and also being shared, you'll see, besides those publications, your certificate of webinar attendance is also being shared, and you can download that. So we have another webinar scheduled on January 21st from 2 to 3:30 on screening and assessment across the sequential intercept model. This is the second in a series of webinars on screening and assessment, and this one will focus on applications and real-life scenarios. So that will conclude our webinar. For those of you who wish to sign up for the Gain Center listserv to stay current with any other webinars and solicitations we might offer, that's the link to get on our listserv. And on behalf of the SAMHSA Gain Center and SAMHSA, thank you for your participation. Good afternoon.